So thank you very much to the organisers for inviting me, and thanks to all of you for voting very low on my side of the argument to start with, because I see that as an easy win. I only have to persuade a few people to change their mind, and I can switch those ratios around. So yeah, my side of the argument is to treat this case early. So we have achieved biochemical progression, and we therefore, I would argue, should be treating this patient. These are my disclosures. So just to get the terms correct in terms of what the arguments are, so if we don't treat it biochemical progression, the only other truly measurable point at which you can decide to start treatment, I would argue, is the point of clinical relapse. So the point of clinical relapse is the point at which Emma's going to let her patient become hypercalcemic, develop a bone fracture, become anemic and need a transfusion, or particularly in the case for this patient, perhaps develop worsening renal failure as they had at their initial diagnosis, or even maybe some more aggressive phenotypes like extramedullary disease or plasma cell leukemia. In contrast, biochemical progression is something we can measure. We can measure it early. We know the definitions that I won't read through, but are laid out here are the definitions of biochemical progression. They're the endpoints of clinical trials, the point at which we say a treatment is no longer working for a patient, and the point at which, importantly, in a clinical trial, we definitely shouldn't treat before this point, because otherwise we can't record progression and then record progression-free survival within the trial. And I would argue that identifying biochemical progression and then intervening is the whole point of seeing all of our patients so regularly in myeloma clinics. So we see them every month or every 2 months. Specifically so, we can see these small changes from an undetectable paraprotein to perhaps a paraprotein of 1, 2, or 3, and then detect that point at which they reach IMWG biochemical progression, and therefore, I would argue, require treatment. And so what are the benefits of treating at that point rather than waiting till clinical relapse? So we treat it biochemical progression. The patient is hopefully feeling well, has a good performance status, a good organ function, a smiley face. If we wait until clinical progression, the patient's probably feeling quite unwell. Their performance status may be dropping. Their organ dysfunction might, in fact, limit what treatment options we can deliver, and therefore they have a sad face. But Emma might argue that even if we don't treat it biochemical progression, we may not need to wait until clinical progression to treat. So she'll tell you that you can just monitor, and we'll keep a close eye, and we'll watch those numbers, and then we'll decide what we can do. But I'm hoping that she's going to tell you that she's got some special skills to do that, because I would argue that there is no other point at which you can tell what is going to happen to your patient. You've got either biochemical progression, or you have to become Mystic Emma. For those who did not grow up in the 80s and 90s, Mystic Meg may be unfamiliar to you, but hopefully by the laughs it is familiar to some people. So we don't all have a crystal ball, so we can't all tell at what point, at what precise light chain level, at what precise paraprotein level that end organ damage is going to occur. And so when we're monitoring patients in clinic, we're just waiting for something to happen, and we're trying to do something before it happens, but we don't know when that's going to occur. And apart from struggling to predict the future, we're also leaving patients with this sense of anxiety about, we have said, oh yes, you've reached biochemical progression, particularly for patients in clinical trials. At that point, we will have stopped therapy, but we don't think you need treatment at the moment. They're thinking, well, but when? When will I need treatment? And so we maybe set some arbitrary limits. We maybe say, oh, when your paraprotein's 10, when your light chains are 500, but we don't know that harm won't happen before that point. And so for one of my arguments, you can think of it as this boiling frogs metaphor, which is about increasing the temperature of water or the conditions around a person. Maybe the patient will start to feel more unwell, but adapt to those new symptoms. And if they had suddenly got all of those symptoms, like the frog going into boiling water as opposed to going into gradually warming water, if they'd suddenly experienced those new symptoms, they would have wanted to change treatment at that point. And often we hear from patients when we do start treatment, oh, I do actually feel better now, thank you. You know, actually this has made a difference to those subtle symptoms that I perhaps couldn't put my finger on or weren't shown in the light chain or paraprotein results. Importantly, I'm going to bring some science into my argument. So if we think about what we understand about clonal evolution in myeloma, then if we know that the tumor is going to evolve over time and become increasingly more complex, perhaps with increasingly more drivers of resistance to different therapies, if we start treatment at one of these earlier time points, the tumor will be less complex and therefore potentially easier to get under control. Apart from science, I also have some data. So this is a study that specifically looked at patients who either had biochemical relapse, which was about 60% of patients, or clinical relapse, which was 40% of patients. And this first analysis was looking at the time until they needed next-line therapy. So you can see that those patients who had biochemical progression, the blue line, had a longer time until they needed next-line therapy compared to those who had clinical progression, and that this is marked out by those with clinical progression by CRAB in green or by aggressive characteristics in red. And maybe you might be concerned that that might represent some kind of lead time bias. If we're starting treatment early, they obviously won't. It will be longer until they might need the next line of therapy. But I can counter that, in case Emma tells you that, by showing you that the overall survival analysis of that same study showed a clear and even greater benefit for treating biochemical progression compared to clinical progression. I'm not going to go through any other studies, but just to point out there are several other studies that have looked at this exact same question and found essentially the same answer. So in summary, my arguments are to treat at biochemical progression, to prevent end organ damage, keep patients feeling well, try and attenuate the anxiety in both the patient and the clinician from watching and waiting, to try and limit clonal evolution, and because it's supported by the data. Thank you.
Very much, Charlotte, and I particularly appreciated the Mystic Emma slide for reasons that will become apparent.